A very good morning to you all. Respected Emeritus Chairperson Dr. M.L. Swankar sir, Achal Gulati sir, V.K. Kapoor sir, Jaiswal sir, all esteemed faculty members, colleagues and dear residents. I welcome you all to this CCR presented by Department of General Medicine. This is our team in one frame. This is the departmental profile. We have total 8 units. Our department has 240 beds with a daily OPD of more than 200 and 50 to 55 admissions per day. Our ICU occupancy is almost 100%. Our faculty members have excellent publications in reputed journals and books. More than 100 publications have been contributed over the past 5 years in high impact factor journals. This is a comprehensive list of the research citations of our faculty members. Backed by strong support from the management and guidance from our seniors, we have been successful in bringing MGUMST on the global examination platform as MRCP PACES Center. Out of the 6 in-house recognized MRCP examiners, 5 are from the Department of Medicine and Professor Hemant Ghantha sir is from Department of Medical Oncology. Here are some glimpses of the March 2026 examination. Women at the forefront of healthcare. I'm happy to share that increasing number of female doctors are now opting for MD medicine as their preferred career. In the final, this first year batch, we have 12 female residents out of 27. Women ensure that every detail is documented and remembered for future reference. Their communication is excellent and so is the interrogation of the patient, of course. Most of our senior faculty members are recipients of prestigious national and international fellowships and awards. Continuing this legacy, the fellowship recipients this year are Dr. Pradeep Agarwal. He has received FRCP Edinburgh, and Dr. Manish Pahadia. He has received fellowship of the Indian Association of Clinical Medicine. Coming on to the academics, our department regularly conducts seminars in the form of case discussions and journal club. PG students have proved to be a great asset to the institution by securing top positions in paper and poster presentations and quizzes at state and national level. We are consistently engaged in academic enrichment activities like PGCR, CCR, and value-added courses like ACLS and BLS. Our department's regular quiz activity promotes a culture of learning and enhanced intellectual development. We are also proud to share that our faculty and residents have authored various chapters in yearly publications of Medicine Update, Indian Association of Clinical Medicine Update, and Reddy Reckner in Medicine. The Department of Medicine has organized prestigious state, national, and international conferences over the years, with Raj IACM Con 2026 being the latest one. It was attended by over 450 delegates from all over the country. These are some snapshots from the conference. We also have represented MGUMST at international platforms. A bit about alumni progression. Postgraduates of our department have progressed to DM in various specialties thanks to the academic environment in our institution. Many have either completed or pursuing DM in reputed institutes like NIMHANS, ILBS, to see a few, and now working as super specialists. Some of them opted for various fellowship programs and senior residency. Most of them joined private practice, and few have also chosen careers as teaching faculty. This is a comprehensive list of our alumni who have progressed for higher studies. We have significant representation both on the national and state level in professional bodies like Association of Physicians of India, Innovative Physician Forum, Indian Association of Clinical Medicine and many more. MGH है तो भरोसा है और हमारी पुरजोर कोशिश है कि हम MGH के भरोसे पे पूरा उतरें। धन्यवाद। Now coming on to our case of a young gentleman whose initial symptoms appeared deceptively simple. He presented with only abdominal pain and jaundice, but the eventual diagnosis to be both rare and unexpected. For this, now I invite Dr. Jatin Kedia to take over the case. Thank you.
Thank you, sir. A very warm good morning, respected Chairman, sir, Vice Chancellor, sir, esteemed faculty members, dear colleagues and residents. Today, myself, Jatin Kedia, is going to present a case of a young male with jaundice and altered sensorium. The case is of a 25-year-old male from Nagaur, Rajasthan, currently living in Saudi Arabia, commerce graduate and employed at departmental store as a shopkeeper, presented to MGH on 29 December 2025. Clinical history is given by patient brother and seems reliable. The patient presented to us with complaint of abdominal pain from the last 4 months, yellowish discoloration of the sclera from last 15 days, recurrent episode of nausea and vomiting since last 10 days, low-grade fever last 5 days, and altered sensorium from the last 3 days. Patient was apparently asymptomatic 4 months back. Then he developed complaint of abdominal pain, and according to the attendant, it was usually limited to the upper abdomen. The pain was insidious onset, gradually progressive, dull aching in character, and radiating to the back. Increase in pain severity since 1 month. No aggravating and relief factor were identified. Patient for this received treatment from local practitioner and was hospitalized for the same at least twice during the last 4 months. Despite the symptomatic treatment, the symptom persists. Patient attendant also complained of yellowish discoloration in the eyes, which was later seen on the chest and abdomen, associated with dark yellow colored urine and generalized pruritus. He also complained of nausea and vomiting from the last 10 days. Vomiting was recurrent, 3 to 4 episodes per day, non-bilious, non-projectile in nature, mainly contained food particle, not associated with blood and vomitus. No significant aggravating and relief factor were identified. He also complained of fever, which was low grade, documented up to 100 degrees Fahrenheit, and continuous type, temporarily relieved after taking medication. Patient attendant also complained of altered sensorium since last 3 days, and according to them, patient was conscious, able to recognize his attendant. However, he was not following simple verbal commands. Occasionally, as per the attendant, he used to have irrelevant talking. Negative history. There is no history of loose stool, black stool, clay colored stool or blood in stool. No history of abdominal distension, rash, headache. No history of focal neurological deficit, seizure-like activity, visual disturbances, loss of consciousness. In past history, there is no such similar complaint. No known history of hypertension, type 2 diabetes mellitus, coronary artery disease, chronic obstructive airway disease, hepatitis, or any chronic medical illness. No history of prior surgery or blood transfusion.
Can I ask a question here?
Yes,
any history of anorexia that you did mention?
No, sir. Actually,
no anorexia.
No anorexia was there.
And over the 4 months, it's difficult to believe that 4 months pain abdomen, 2 times hospitalization, and ultrasound would not have been done. Anything in
Sir, actually, ultrasound had been done. I will show in 2 coming slides. I'm going to show that. In personal history, patient consumed mixed diet, but appetite was reduced significantly, and patient also has altered sleep pattern, rest interval normal, no alteration bowel and bladder habits, no history of any substance abuse. Family history was not so significant. Treatment history. Over the preceding 4 months, the patient consulted multiple doctors for similar complaint. The patient had been admitted to a local nursing home in Didwana on at least twice occasion for abdominal pain and related symptoms. Symptomatic treatment was administered, resulting in partial relief. Treatment received include proton pump inhibitor, antacids, ursodeoxycholic acid, and intravenous antibiotics. No significant clinical improvement was noted despite the treatment. These were the...
Excuse me, have you had any history of any other complementary other medicines he has taken, like Ayurvedic or Unani?
No, sir.
medicine?
We have specifically asked about the Ayurvedic medication, but as per the history provided by the attendant, they said there is no history of any Ayurvedic medication. Yes, sir. But history was provided by the attendant, and they said they haven't taken any medication. Sir, patient was in altered sensorium. He was not able to give the history. These were the outside hospital reports, in which we can see there was mild transaminitis on 8 December, followed by...
Then you should specify what grade of the altered sensorium was there. Like simple grade 1 or grade 2, or when the confusions are there, they can
Okay, sir.
talk,
Like
no?
the patient has altered sensorium in the way of irrelevant talks. He is not obeying simple verbal commands and not oriented to time, place, and person. Followed by hyperbilirubinemia. Both direct and indirect bilirubin were raised with pancytopenia. These were the outside report. USG suggestive of bilateral renal calculi. Rest all was normal, and upper GI endoscopy was done suggestive of fundal gastritis. So, to summarize the timeline, we have a young male with upper abdominal pain radiating to the back with progressive worsening over the past month, followed by development of jaundice, pruritus, dark yellow colored urine, low grade fever with chills from last 5 days, and altered sensorium with incoherent speech and inability to follow commands presented to our hospital MGH. So, what could be the probable diagnosis on the basis of the clinical history and past investigation? And okay, any other? Okay, any more? It's okay.
So in the history there are 2-3 specific things, no? Long history of pain abdomen, and itching is quite prominent. So would you think of obstruction in this patient? Yes.
Yes, sir.
Obstruction,
Yes.
some kind of obstructive jaundice you
Like,
may think of.
yes, sir. We can think, like, according till now we can think there can be obstructive jaundice, and the many causes can be there for obstructive jaundice. On the basis of the history, the probable diagnosis could be infectious or inflammatory. In infectious, we consider acute cholangitis, liver abscess, tropical fever, hepatitis. In inflammatory causes, we consider choledocholithiasis, pancreatitis. Now let's come to the examination part. On general physical examination, patient is conscious, not oriented to time, place, and person. His BP in supine position in right brachial artery was 110 by 78 mmHg, and pulse in right radial artery was 88 beats per minute, regular with normal rhythm, volume, and character. No radioradial or radiofemoral delay was present. Has 98% saturation on room air with auxiliary temperature of 98.7 degree Fahrenheit, measured using digital thermometer. On general physical examination, pallor icters were present and bilateral pitting pedal edema was there. Now let's come to the systemic examination. On GIT examination, abdomen is scaphoid in shape, no visible scar marks, dilated vein, pulsation or discharging sinuses. All 4 quadrants move equally with respiration. Hernial sites were normal. On palpation, generalized tenderness was there, no guarding or rigidity. Liver and spleen were non-palpable. On percussion, tympanic note here in all 4 quadrants. Liver span was 15 cm in right mid clavicular line. On auscultation, bowel sounds were present and normal, no abdominal bruit or venous hump. Let's come to CNS examination. His GCS was E4, V3, M5. MMSC score, mini mental, state examination score we could not assess. On cranial examination, cranial nerve 3rd, 4th, 6th and 7th were apparently normal, others we could not assess. Bulk and tone was normal, power was at least 3/5. DTRs were normal, plantar were fracture, involuntary movements were absent, coordination and gait we could not assess. Sensory examination, cerebellar signs and fabric tremors could not be assessed. Signs of meningeal irritation were absent. Cardiovascular system was normal, heart sounds were present, no added sound were there. Respiratory system was normal, bilateral ANT present, no adventitious sound. So till now the summary is 25-year-old male with abdominal pain, yellowish discoloration of the sclera, fever with chills and altered sensorium. On examination, pallor, icterus and bilateral pedal edema was there, and investigation suggestive of pancytopenia with lymphopenia with de-enriched liver function test. So again, what could be a probable diagnosis after examination? Okay. 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 Okay, sir. Yes, sir. Yeah. Okay. Okay. On the basis of the summary and past investigation and clinical examination, we have divided a probable diagnosis in our 4 categories: infectious, autoimmune or inflammatory, metabolic or genetic, toxin and drug related. These were the differential that we have considered. Okay. On admission of the patient, symptomatic and supportive treatment was started promptly to stabilize the patient. IV antibiotics were started. After sending blood culture reports, hepatic encephalopathy was managed with seroblactulose and target stool of 3 to 4 times per day. Supportive management include Rice tube feeding, Foley's catheterization and baseline investigation were sent.
Just query.
Yes, sir.
Do you feel ceftriaxone would be comfortable in a hepatitis child?
Yes, sir. We can give.
Crystallization is quite common in that.
Sir, but like.
Anyone else? Ceftriaxone.
What was the need for
Sir.
give empirical antibiotics just for such a high level antibiotic?
And I think there is some clinical evidence of cholangitis is there, fever with chills and obstructive jaundice, so that would be reasonable, I think.
These were the investigation that we have sent. In this we can see there is anemia with thrombocytopenia and raised ESR and CRP, and PVF shows erythrocytosis with and giant platelets. In this investigation there is hyperbilirubinemia with direct bilirubin raised more than indirect and mildly raised ALP and hyperalbuminemia. In this investigation we can see both amylase and lipase are raised, and lipase is significantly raised. All other tropical panel reports were negative. In this report we can see ammonia is less than 9, LDH is mildly raised, and stool routine and urine routine was normal, TSH was normal, thyroid profile was normal. Fasting lipid profile was also normal. This is the USG report of abdomen, revealed a bulky pancreas with heterogeneous echo texture, no calculi seen in gallbladder. There were no dilatation of the intrahepatic biliary radicals, and there is heterogeneous echo texture of hepatic parenchyma with minimal ascites. With the baseline investigation, A working diagnosis of acute pancreatitis, acute hepatitis with altered sensorium and hematological abnormalities was made. So what next? On the basis of the summary and hospital investigation, we have ruled out some of the differentials: acute liver failure, tropical infection, hypertriglyceridemia associated pancreatitis, drug-induced pancreatitis, drug-induced hepatitis. After the initial review, patient was evaluated further to rule out other causes of pancreatitis, hepatitis associated with altered sensorium and pancytopenia. ANA by IFA, we sent this investigation. ANA by IFA, asthma, anti-LKM, AMA, IgG and IgG4, serum celloplasmin level, slit lamp examination of the eye and iron profile. We also planned for CCT whole abdomen, and simultaneously hepatology opinion was taken. Now I would like to call Dr. Hemant sir from Department of Hepatology to take the case further.
Good morning, my teachers, respected dignitaries and my colleagues. My name is Hemant. I am Hepatology DM resident final year in Mahatma Gandhi. We have been referred a 25-year-old male who presented to medicine department with complaints of jaundice, abdominal pain and altered sensorium. So almost presented like a case of acute liver failure, because we have to rule this out as patients with acute liver failure require urgent medical assessment and management. But in this patient, ammonia and INR are normal, which rules out acute liver failure. And also this patient had acute pancreatitis suggested by abdominal pain, raised amylase and lipase, and bulky pancreas on ultrasound, along with bicytopenia. Suggestive almost suggestive of a systemic disease rather than an inherent liver pathology. So multiple systems are involved: liver, pancreas, brain, and hematological manifestations. Most likely these kind of systemic disorders are caused by infections or autoimmune disorders. However, still common causes of pancreatitis and hepatitis are gallstone disease and alcohol, which in this patient are ruled out. And autoimmune causes like autoimmune hepatitis, autoimmune pancreatitis, SLE, systemic lupus erythematosus, IgG4 related disease can cause this kind of manifestations. Viral causes like hepatitis A, E and B, which in this patient have become negative, and non-hepatotropic viruses like cytomegalovirus, Epstein-Barr virus, herpes simplex virus and varicella zoster virus can cause this kind of manifestations. And some other cause diseases like dengue, malaria, scrub typhus and leptospirosis present like acute liver failure presentation, like present with jaundice, altered sensorium and raised OTPT. And other causes like genetic disorders, which in this case actually in 25-year-old male are unlikely. So our advice is to evaluate further for autoimmune etiologies with ANA, ASMA, IgG, anti-LKM1, anti-liver cytosol 1 antibodies, serum IgG4 levels, and non-hepatotropic viral markers for IgM cytomegalovirus, IgM Epstein-Barr virus, IgM varicella zoster virus, and IgM herpes simplex virus, and to evaluate for ALF mimics with leptospira IgM antibody, and to get a cross-sectional imaging with CCT abdomen to look for complications of pancreatitis and liver disease. Now I would like to invite Dr. Anjali from Department of Radiology for...
So Hemant, we are looking for a cause which is producing inflammation in both the liver and the pancreas,
yes,
right?
Now I would like to invite Dr. Anjali from Department of Radiology to discuss regarding CCT findings.
Thank you, Dr. Hemant sir. Good morning everyone. My name is Dr. Anjali. I am from Radiology, second year resident. I'll be discussing the CCT abdomen findings. So, how does normal pancreas appears on CCT? It should measure approximately 3 cm head region, 2.5 cm body, and tail approximately 2 cm. In our patient, head, body, tail appears diffusely bulky. There was mild peripancreatic collection. And no intrapancreatic calcification or necrosis is seen. The pancreatic duct is not dilated. There was soft tissue stranding and inflammatory changes seen in the peripancreatic and mesenteric fat with thickening of bilateral and renal fascia. There was bilateral trace pleural effusion. There was periportal edema and pericholecystic edema also. So diagnosis, acute interstitial pancreatitis with mild ascites and bilateral trace pleural effusion. So modified CT severity index was 6 out of 10. There was diffuse hypoattenuation of hepatic parenchyma with periportal and pericholecystic edema - query hepatitis. There was no radiodense calculus seen in the gallbladder, no dilatation of the intrahepatic biliary duct, and normal caliber of the common bile duct. So how do we give the CT severity index? There are 3 points: inflammation, necrosis, and extrapancreatic complication. In our patient, there was minimal peripancreatic fluid collection, there was no necrosis, trace pleural effusion, and minimal ascites. So we gave a score of 6 out of 10.
Thank you, Dr. Anjali. These were the further investigation, and this, as we can see, ANA by IFA is positive, and other antibodies, anti-LKM1, AMA, and asthma are negative. This is the ANA report, which is positive, showing homogeneous pattern, 3 plus grade, and titer is more than 1:80. So, following the ANA positivity report, a focus reassessment of history was undertaken to identify other manifestation of SLE. In this case, we have neuropsychiatric symptoms, constitutional symptoms, and serosal symptoms. Musculoskeletal and mucocutaneous renal symptoms were not there. This is the Euler criteria of SLE. In our patient, constitutional domain was there, neurological domain was there, serositis domain was there, and hematological domain was there. According to the Euler criteria, there should be ANA positivity, and more than 10 points should be there, and at least 1 clinical domain. So we fulfill all this criteria. And after that, we have sent the ANA profile of the patient, in which we can see these antibody positive, dsDNA antibody positive, Stone, Smith, PCNA, ribosomal P, and SSA were positive. And there is also weak positive PMSCL antibody. In this investigation, we can see that serum ceruloplasmin level was normal, serum ferritin was raised, and TIBC was below normal, and there was mild non-significant elevation of IgG4 levels. On ophthalmological examination, there was no papilledema and no KF ring was there. So, till now, we have a 25-year-old male with fever, altered sensorium, pancreatitis, and polyserositis with ANA profile suggestive of positive antibodies, dsDNA, Stone, Smith, ribosomal P, SSA, PCNA, PMSCL with leukopenia, thrombocytopenia, and anemia. So, our final diagnosis is acute severe SLE with neuropsychiatric manifestation, pancreatitis, hepatitis with cytopenia, and polyserositis. So, with the diagnosis of acute severe SLE, patient was started on pulse methylprednisolone therapy. Rest treatment was continued. However, after 3 days of pulse steroid therapy, patient developed seizure-like activity along with worsening sensorium characterized by tonic-clonic movement involving the right upper limb, frothing from the mouth, and at the same time, neurology opinion was taken. Now I would like to call Dr. Samparna ma'am from Department of Neurology to take the case further.
Thank you, Dr. Jatin. Good morning, respected seniors. I am Dr. Samparna from Department of Neurology. Summarizing till the seizure event timeline, 25-year-old male patient with no known prior comorbidities presented with abdominal pain, jaundice, dark colored urine, fever, altered sensorium. After detailed clinical evaluation and lab investigation, diagnosis of SLE was established, for which the patient was initiated on pulse methylprednisolone therapy once daily for 5 days. On the 3rd day of pulse steroid therapy, the patient developed an episode of abnormal tonic posturing involving the right upper limb followed by frothing from mouth, suggestive of a focal onset seizure with impaired awareness and possible secondary generalization. Patient presented with focal right upper limb tonic posturing, followed by frothing during the episode, impaired awareness. On clinical examination, patient was E4V3M5. Due to poor sensorium, his motor sensory system could not be assessed, cerebral signs could not be elicited, meningeal signs were absent. Our differential diagnosis on the basis of clinical assessment was kept as neuropsychiatric manifestation of SLE, SLE disease itself causing seizure, secondary CNS infection because of immunosuppressive status, metabolic encephalopathy leading to symptomatic seizure, aseptic meningitis associated with SLE. Investigation as advised as neuroimaging to look for any structural abnormality, CSF to look for secondary infection, neurotelemetry monitoring to capture events and document. The MRI findings showed chronic ischemic demyelinating changes which can occur as a part of neuropsychiatric manifestation in SLE. There was no focal mass lesion. There was generalized cerebral and cerebellar atrophy, no parenchymal meningeal enhancement and no significant midline shift. The CSF analysis was overall normal. EEG captured event which had an ictal correlate on the EEG which showed in metabolic disturbances. This is generalized slowing. On the basis of clinical evaluation and investigation, the impression was kept as neuropsychiatric manifestation of SLE versus overlap SLE disorder related symptomatic seizures. Now I would call Dr. Jatin to continue.
Thank you, Dr. Samparna ma'am. After neurology opinion, patient was started on anti-epileptic therapy and steroids were continued. Patient shows initial sign of recovery, but on day 13, patient developed irrelevant talk and abusive speech, aggressive behavior and disturbed sleep pattern. Differential diagnosis for this event considered were exacerbation of neuropsychiatric lupus manifestation, could be electrolyte imbalance, steroid-induced psychosis. On that day, electrolytes were normal, so we have ruled out electrolyte imbalance. In view of above symptoms, a psychiatric consultation was sought for further evaluation and management. Now, I would like to call Dr. Poornima from Department of Psychiatry to take the case further.
Thank you, Dr. Jatin. Good morning, everyone. The patient was a 25-year-old male who was referred for psychiatric evaluation on 13th day of admission. According to the attendant, he has disturbed sleep for the last 16 days. He also developed irrelevant speech and irritability, which is unprovoked since 12 days. The illness had an abrupt onset with a continuous and progressive worsening course. There was no past psychiatric history and no family history of psychiatric illness. On mental status examination, patient is examined in ICU while lying on the bed appeared restless, untidy and unkempt. Although eye contact was initiated but not maintained, he was uncooperative and rapport could not be established. Psychomotor activity was increased with active hallucinatory behavior was observed. Speech was audible but irrelevant and non-goal directed. Mood could not be assessed, affect was inappropriate. Thought and perception could not be elicited. On higher mental function, patient is inattentive and not oriented to time, place and person. Insight was impaired. Several differential diagnoses were considered. First, delirium include neuropsychiatric lupus, encephalopathy, metabolic disturbances due to pancreatitis, systemic inflammation. The second possibility was a other mental disorder due to brain damage and dysfunction due to physical disease. Third, psychotic disorder due to multiple drug use or steroid-induced psychosis. Finally, the acute and transient psychotic disorder. Differential diagnosis of other mental disorder due to brain damage and ATPD was ruled out due to because the patient is usually attentive and the orientation to time, place and person is intact in these disorders. Psychotic disorder due to multiple drug use is also ruled out because the psychiatric symptom manifested before the exposure to steroid. So our final diagnosis based on the clinical picture and course of illness is F05 delirium as per ICD-10 diagnostic criteria. Coming to the treatment, the mainstay of treatment is treat the underlying cause of delirium. For symptomatic management, patient was started on low-dose antipsychotic. Olanzapine 2.5 mg at night was prescribed, and the patient was advised for reassessment after 3 days or earlier if required. On 15th day of admission, the attendant reported improvement in irrelevant talk. Sleep disturbance and irritability persisted but had reduced in severity. On repeat mental status examination, psychomotor activity, though still increased, was better than before. Speech was relevant and goal-directed. Patient was attentive and fully oriented to time, place and person. Insight was intact. In view of partial improvement but persistent symptoms, olanzapine was optimized to 2.5 mg twice daily and advised to review after 3 days and SOS. Non-pharmacological management of delirium. Environmental modifications include maintain a calm and quiet environment, ensuring adequate lighting and keeping familiar objects nearby. Serial reorientation help reduce confusion by repeatedly reminding the patient of the time, place and current circumstances. Maintain sleep hygiene. These interventions often reduces the severity and duration of delirium and improve the overall outcome. Thank you everyone. I would now like to hand over to Dr. Jatin for the further.
Thank you, Dr. Poornima. Following psychiatric consultation, the patient was started on antipsychotic therapy with olanzapine, oral steroid therapy, and rest of treatment was continued. Subsequently, the patient showed significant improvement in sensorium. Patient became ambulatory and was mobilized out of bed. Ryle's tube was removed. These are the serial reports of the patient during admission, in which we can see there was progressive improvement in LFT and hematological parameters. On day 18, the patient was shifted to the ward. Patient was continued on oral steroids and antipsychotic medication. The patient was discharged on day 19 on tablet prednisolone, olanzapine and levetiracetam and supportive management, and advised to follow up 7 days after with CBC and LFT reports.
Any specific reason for giving the steroids twice a day?
Sir, actually, initially we are gradually tapering the dose.
So you can give once a day steroids and taper it off also, no?
Sir, but like according to the guidelines, it was like you have to give in divided doses and SLE.
So dose was very high, 60 mg one, plus the patient in patients who are of autoimmune disorders, we generally prefer that they can be divided in 2 doses. Otherwise, there is no specific reason for giving it twice a day. Can be given once a day, but in autoimmune disorders, we generally give them twice. Morning dose can be higher. Yes, sir. The morning dose can be higher.
These are the follow-up visit of the patient. After 1 week, patient has significant hepatic and neurological recovery. Sensorium improved markedly. LFT trending towards normal. After 1 month, transition of immunosuppression, corticosteroids gradually tapered, and mycophenolate mofetil was started. And on 3-month visit, patient returned to independent daily life, performed all activities of daily life independently, and has resumed routine work. These are the follow-up reports of the patient, which shows progressive laboratory improvement. Now, I would like to call Dr. Devendra, sir, from Department of General Medicine to take the case further.
SLE is chronic autoimmune disease in which organ and cell undergo damage initially mediated by tissue-binding autoantibody and immune complex. Around 90% of patients are women, especially during childbearing age. In Indian population, the prevalence of SLE is 3.2 per 10,000 population. There are various manifestations of the SLE. The most common is the mucocutaneous and the musculoskeletal. What makes this case unique? In Indian population, SLE prevalence in young adult male is 1.5 to 6 per lakh. Reported prevalence of pancreatitis is 0.2 to 8%, but as the initial presentation of SLE is very rare. Also reported prevalence of hepatitis is 3 to 23%, but as the initial presentation of SLE is very rare. In our patient, pancreatitis and hepatitis were the initial manifestation of SLE in young adult male. CNS lupus is currently referred to as the neuropsychiatric systemic lupus erythematosus. Include the neurological and the psychiatric manifestation. SLE involving both central nervous system and the peripheral nervous system. Among the central nervous system, cognitive dysfunction, mood disorder like depression and mania, and the headache are most common. Mononeuropathy and polyneuropathy are the most common peripheral nervous system manifestation. Now coming to the pathophysiology. The pathophysiology of NPSL is begin with the loss of self-tolerance and production of the autoantibodies like anti-dsDNA antibodies, anti-ribosomal P antibody, anti-NMDAR antibody. The two main mechanisms are considered in the NPSL. One is the vascular or the ischemic injury, and second one is the inflammatory mediators which disturb the blood-brain barrier, and neural injuries will happen. There are some key antibodies most commonly seen in the NPSL patient like anti-phospholipid antibody, anti-ribosomal P antibody, and NMDAR antibodies. In our patient, the anti-ribosomal P antibody are strongly positive. The management of the NPSL begin with the first rule out the secondary cause like infection, metabolic disturbance, or the neoplasm. If the secondary cause was present, then the diagnosis is the secondary NPSL and treat accordingly. If then we see the favoring factor in NPSL, generalized disease activity, previous major NPSL, anti-phospholipid antibody positive, abnormal CNS imaging, or the abnormal CSF. After then we made the primary diagnosed primary NPSL in like our patient. Then we divided management based on the mechanism. If we presume the immune mediated mechanism like in our patient like a myelopathy, psychosis, or the confusion, then treat accordingly with the immunosuppression. And if we presume the thrombotic mechanism based on the antiphospholipid antibody are positive or not, and treat accordingly. To place our case in context, we reviewed some cases, case report. In this case report, a young male came with the initial presentation of pancreatitis of the SLE. In a patient with unexplained pancreatitis, especially with the cytopenia, proteinuria, pleural effusion, thrombosis, and positive ANA or the dsDNA, clinicians should be strongly consider the SLE. This is the case series from the South China. In which the 27 patient of the lupus pancreatitis is observed, and the found that the neuropsychiatric manifestation among the major concomitant organ involvement observed in the this patient. Take home message: in our patient, a typical atypical presentation in young male with the typical atypical SLE presenting predominantly a pancreatitis, hepatitis, and the neuropsychiatric manifestation. Rare initial presentation with pancreatitis and hepatitis. Atypical in young male, maintain the high index of suspicions. Autoimmune workup, strong autoantibody profile with multi-system involvement should prompt the autoimmune evolution. NPSL diagnosis may occur even with the normal CSF and the normal brain imaging. Early diagnosis and early treatment, early immunosuppressive therapy improve the outcome. Key message is the SLE should be considered in the differential diagnosis of the young male presenting with the pancreatitis, hepatitis, and neuropsychiatric symptoms. Even in the absence of the classical mucocutaneous manifestation, a comprehensive autoimmune workup and the early immunosuppressive therapy are critical. This is the testimonial video of the patient.
मेरा नाम आमिर खान है, मेरी उम्र 26 साल है, मैं नागौर जिले का रहने वाला हूँ। मेरा पेट दर्द बहुत करता था, मैं सऊदी अरब रहता था, फिर मैं इधर इंडिया में आ गया। इंडिया में आया तो मैं बहुत जगह दिखाया डिडवाना जिले में, तो कुछ भी फर्क नहीं रहा। एडमिट भी रहा मैं उधर कुछ भी फर्क नहीं था। टेबलेट लेता था, 2 दिन ठीक रहता था, वापस वही दिक्कत होती थी। फिर कोई किसी गांव वाले ने बोला कि आप महात्मा गांधी हॉस्पिटल जाओ जयपुर। फिर मैं इधर आया तो मुझे कुछ भी होश नहीं था, मेरा दिमाग वगैरह कुछ भी काम नहीं कर रहा था, कुछ भी होश नहीं था मुझे। फिर मैं इधर 20 दिन एडमिट रहा, मेरा इलाज चला, अब मैं एकदम ठीक हूँ, एकदम स्वस्थ हूँ। महात्मा गांधी स्टाफ का तहे दिल से शुक्रिया।
How long will you continue with the antipsychotic treatment in this patient?
Antipsychiatric,
Sir, he's on antipsychotic drug.
Sir, in last follow-up, we stopped the antipsychotic because of the no any symptoms. A patient is healthy and doing his routine life, and is the plan for वापस दुबई जाने का plan कर रहा है after 3 months के बाद.
Don't you think because primarily it is the neuropsychiatric involvement of SLE?
Yes, sir. Because of the
So
primarily lupus.
What will be the chances of relapse if you stop the antipsychotic drugs?
Sir,
every treatment is by steroids, sir. So once he is stabilized on steroids, then we can stop antipsychotic medication.
because the sir symptoms is basically the primarily due to the lupus. That's why we continue the corticosteroid.